Yes. Right.
Can I see at the moment how many people are already logged in?
Uh, yeah, saying I think 54. Today
900,
morning
right?
was 114 people.
The couple of sleeping. Okay. Good afternoon. I will wait for a bit because we have only 60 people logged in at the moment. So shall we give a couple of minutes until people who have fallen asleep logs in? Is there another lecture at 3 o'clock?
Uh, I think no.
No, no. Sorry, I won't take that much time. Yeah, I think we should start off now. So basically, this is the second part of the arrhythmia management lecture, which I did the approach to tachyarrhythmias last week. And today we are going to talk about the bradyarrhythmias. Right? So essentially, uh, let's start there. Right. So, like last time, basically we are going to start off with the questions, and I think you all have been sent the question paper for the body arrhythmias, and you would have got a title sheet body arrhythmias post and pre and post lectures knowledge test. I think I'll give you about 5 minutes for you to go through all the 4 questions and then answer as you can. Again, this is a self-assessment, so there's no worry about anyone knowing what they went right or wrong. So we are fine with that. And so I'll give you 5 minutes, maybe 10 to 10, and look at the questions and answer questions. And as earlier, you mark them in the pre-column, pre-row of the table, because once you do the lecture, we are hoping that you be included and you will mark at the post. Okay, right. So let's start. See what happens. I'll just knock off my video for a shift until that time. Okay, so hopefully most of you are done. I just give a couple of seconds more. Shall we keep that aside and get on to the lecture? Okay. Right. So we start. Let's remind you of the conducting system of the heart. If you're home, now we know that in the heart there's an electrical system which consists of the sinus node, which is the electrical generator, the principal generator of the heart. These are distinct tissue, which is you can see macroscopically between the junction of the superior vena cava and the right atrium. Now, the impulses that are generated from the sinus node spreads along the two atria, enters the AV node. Actually, the AV node is not a distinct entity, but is a collection of fibers. So it's more like we call it the AV junction. And from the AV junction, the impulses travel through the his bundles to the right and left branches of the left the bundle branches. The left again dividing into two, and then end up in this Purkinje system, which is at a lace-like system, which kind of which is in the endocardium of the myocardium and of the myocardium. So basically, the impulses, while they travel through the muscles cells from the sinus node to the AV node, when it comes to ventricle, there is more or less simultaneous activation because there is this Purkinje fibers are there. So that is basically the function. That is how the structural function or structural uh, concept of the conducting system. Now, so if you look at bradycardias, the causes of bradycardias, they are twofold. They could be due to diseases in the sinus node itself, that we call the six sinus syndrome, or there could be problems in the AV conducting system, which we generally just call AV block. These could be primary in the sense that it could be a kind of primary problem in these systems themselves. Generally, they are degenerative, whether it's AV node or in AV node dysfunction or sinus node dysfunction. In sinus node dysfunction, most of the time is degenerative, and you see it in older people. As time goes, there's degeneration of the tissues, right? When it comes to secondary causes of sinus node dysfunction, they are rarer, but you have to think of things like hypothyroidism, hypothermia, and of course some medications can cause. So there are iatrogenic causes as well. When it comes to AV node disease, you can have congenital AV blocks, which are not uncommon, and you can actually diagnose this in utero, in when you do ultrasound scans, or you can do check the fetal heartbeat. They might have slow heartbeats, and at birth they will have heart blocks. Right? Again, there's some degenerative component there. So there are some people who, as they get older, the degenerative changes take place, and they get heart blocks. Secondary causes are not uncommon at all. Then again, medication important. Ischemic heart disease is another important cause of acquired secondary AV node disease. And of course, sometimes cardiac surgery, after cardiac surgery, we see these complications because there is the manipulation of the heart and impinging of the various cardiac devices that they put into the heart can cause AV node dysfunction. Toxins also, particularly toxins like you would have heard of Kaneru poisoning, for instance, can cause AV node disease. So these are the kind of, so basically these two, sinus node disease and AV node disease, are the two conditions which cause bradycardia, right? Okay, that's right. If you look at how would this present on the ECG, remember that these are actually ECG diagnosis. You diagnose these different conditions by looking at the ECGs of this patient. Right? So if you look at sinus node dysfunction, they can present with sinus bradycardia, sinus causes of tachybrady syndrome. What do they look like? So sinus bradycardia looks like this. Now you hopefully you remember the last week's discussion, and we told how to decide whether a patient is having a sinus rhythm or not. Right? So here you see a ECG which obviously shows a bradycardia, the heart rate less than 40 beats per minute. And if you look at every PQRS complex, it is a what we call sinus beats, because every P wave is followed by QRS complex, and every QRS complex is preceded by a P wave. So here we have sinus bradycardia, right? Okay. Now, so compare that. Second kind of ECG you might see is the so-called sinus pauses, where you have a sinus rhythm, suddenly there is a pause. This is due to the fact that the sinus node suddenly stops. So there is either it may be it's like an engine which suddenly misses. So there is missing of the generator, and therefore you get this sinus pause. Other type of condition of ECVC is what is called tachybrady syndrome. These patients, because their sinus node function is poor, what happens is that in the atria, various other rhythms start occurring. So here you find the bradycardia, here actually the junction beat, sinus bradycardia, and suddenly you have a fast rhythm. So this is called tachybrady syndrome. These are the three kind of ECG presentations of sinus node dysfunction. What about heart block? Now we know that there are three types of heart. I still don't know whether you all have lectures on these, but hopefully you have. So you have three types of heart block: first, second, and third degree, and each degree is worse than the first. Now, if you look at first degree heart block, these patients do not present with bradycardia, because why? There is only delay in the conduction of the impulse from the through the AV node. So therefore, you know that in the ECG, the conduction along the AV conducting system is denoted by the PR interval. So that's what you see is only a PR prolongation. But every P wave is conducted to the QRS complex. So therefore, you won't see any bradycardia at all. So you will see something like this, where you have rate is fine. Every P wave is conducted as a QRS complex, but you will note that the PR interval is very, very long. So here, where a PR interval is usually within one big square, here it's kind of nearly two squares. So that is the first type of heart block, which is called first degree heart block. When it comes to second degree heart block, there are two types: Mobis type 1 and Mobis type 2. Mobis type 1 is also called Wenckebach. That is the guy called Wenckebach discovered or described it, right? And in that, what you see the gradual prolongation of the this will be PR interval followed by non-conductor P wave. This is what you see. So here, if you nicely, you can see here the PQRS, there the PR interval. This PR interval slowly prolongs and becomes very long, and then the next P wave is not conducted. This also demonstrates a very important feature of the AV conducting system, which is that AV conductor system is decremental in the sense that now the faster the impulses come to the AV node from the atria, the sinus or other beats, the slower it conducts. So this is a protective feature of the AV node, because you don't want very, very fast rhythms being conducted the same rate to the ventricle. So for instance, if you take atrial fibrillation rate can go up to even 400 to 600 beats per minute. And if it conducts one-to-one through the ventricle, through the AV conducting system, the ventricle won't be able to cope with such a fast rate, and the patient will die. So this detrimental feature of the detrimental conduction feature of the AV node is very, very important to prevent dangerous events. Right? So this is so again, therefore, so here what happens, because at each P wave reaches the AV node, it finds it more and more difficult to go down and run this block. So this is what you see in back type, right? In Mobis type 2, this is a fixed block. So that means some beats are conducted, some beats are not conducted. Generally, so you see a thing called 2-to-1, 3-to-1, or 4-to-1, depending on the beat that is conducted. So you might have the second beat or third beat or fourth beat conducted, and as I said, this is the PR interval that is fixed. So here you have a situation where you can see 1, 2. So this is a second, first beat is not conducted, second. So the 2-to-1 block. And you can see the PR interval in each of these is exactly the say there is a fixed block, right? Okay, that's the type 2. When it comes third degree heart block, we also call it complete heart block. There what happens is there is total non-conduction of the AV across the AV junction. So basically there is no relationship between the P wave and P rate and the QRS rate, and you see a ECG like this, where you can see that there are lots of P waves and very much less QRS complexes. Somebody might say, but isn't this conductor? But in any case, our when cannot define the sinus rhythm, because what our definition means that every P wave must be followed by QRS complex, and every QRS must be preceded by QRS P wave. This can happen. And if you look very carefully, you can see that as the rhythm goes, this PR interval becomes short and short, and here actually the P wave kind of is hidden in the QRS complex. What does that mean? That this cannot physiologically happen. You can't have, in a particular patient who has an AV node problem, you can't have a PVV conductor so fast down the AV conducting system. So this is just coincidental, and so therefore this is a complete heart block, right? Now, this is a very important slide. Why is it important? Because this slide, if you understand this slide, and if you remember this slide, for the rest of your life, you will find it extremely easy to decide whether the patient is having, when you see a bradycardia ECG, the patient is having a sinus node problem or a AV node problem. Right? So if you have a bradycardia ECG and if you don't see any P waves at all, then what does it mean? It means that the sinus node is not functioning at all. So we call it sinus arrest. And the ECG will look something like this. You can see that you have a very slow heart rate. QRS looks normal, but you can't see any P waves at all. Why? Because the sinus node has completely stopped working. So it's sinus arrest. And this is therefore, there is what you call a junctional escape rhythm. This concept of junctional escape rhythm occurs in a situation where the main generator is not functioning. So some kind of tissue, of conducting tissue below the point of block starts a rhythm, and that's called escape rhythm. So you have an escape rhythm. See, since here the sinus node is the one that is blocked, the escape rhythm starts from the AV node. And because it's from the AV node, it conducts normally down the AV conductor system, you have more or less normal looking QRS complex. Okay. Now, if there are P waves, however, then the question is yes. So you have bradycardia ECG, you have P waves. Then you have to look and see whether this is a sinus rhythm. Remember, our criteria, every P wave must be followed by QRS complex, and every QRS complex must be preceded by P, right? And here in that situation, so therefore here you have a bradycardia, but here every P wave is followed by QRS complex. Every QRS complex is preceded by P wave. So it's still a sinus bradycardia. Still shows that there is sinus dysfunction, but it is and it is sick sinus syndrome. What happens if there is a bradycardia and you see that there are some P waves are not having a QRS complex, like this one which showed earlier. So here you have P waves. This P wave has a QRS complex. Therefore, this is and this QRS complex preceded by P wave. This is a sinus beat. So the next beat has only a P wave, no QRS complex. So here you have a non-sinus rhythm, right, essentially. And because some of the P waves are not conducted, then this is a heart block, the AV conduction. So if you remember that, then this is a very, very useful thing to remember, and you will never miss a diagnosis of 5-6 sinus syndrome of AV node disease. Okay. So since it's an interactive lecture, we are going to go from clinical cases, and I'll be asking you some questions which you can reply on the whole system, right? So this is an older woman who came to the GP for be treated for a cough. The GP felt her pulse and found it low. Right? Then he did an ECG and sent the patient to the OPD. Right? When the patient came, the patient is fine. Patient is normal. Patient says, I have no problem. Only thing you find is that the heart rate is on the slow side. Right? And this is the ECG that patient has brought with her. Therefore, just look at ECG for a couple of seconds, and we'll ask some questions, right? So now let's get to this whole. So polls, right. So I'm launching the poll now. Have a look at the possible answers are: is it a six-sign syndrome? Is it a high-grade second-degree heart block? Is it a morbid type 1 block, complete heart block, or junctional bradycardia? Right. So you can start answering the questions now. Right. I'll give you a couple of seconds. Fail. Yes. Okay. Should at least achieve 50% of the audience, I think. So, right, so we have people voting, and we end the poll there, right? And therefore you see the result. So basically, most of you have said it's a six-sinus syndrome. There are people who have said it's a high-grade second-degree block, Mobis type 2, and a complete heart block as well. Right. Okay. Right. So just we close that for the moment. The answer is yes, it's a six-sinus syndrome. Why can't it be high-grade second degree? Why is it not a high-grade second-degree heart block or a Mobis type block or a complete heart block? Why? Because every P wave is followed by a QRS complex. So therefore, this is a sinus syndrome. There is no evidence of AV node conduction block here at all. So therefore, this second two, 3, and 4 cannot be correct. And it's not a junctional bradycardia. Junctional bradycardia, as we said earlier, will not show any P waves at all. So therefore the answer is 6 cents. Okay. Right. So now what I'm going to do for this patient, we'll go to the polls again. We have several options. So these are the options you have. Right? Are you going to admit the patient for observation? Are you going to admit the patient for referral? Are you going to admit the patient for further investigation? Or are you going to just tell the patient, oh, everything's fine, don't worry about it, go home? Or are you going to give the letter,